Hey everyone, today we're diving into something really critical, pediatric trauma. And it's a field where getting one simple thing wrong, well, it can have huge consequences. It really all boils down to one single fundamental idea. So let's get right to it. Here's the big question that every single emergency provider has to face. When it comes to major trauma, are children just little adults? Can you just take the adult rulebook, shrink it down, and call it a day? The answer is a huge, resounding no. They're not even close. And really, understanding why is the absolute key to handling these incredibly tough situations. So let's break down exactly what makes them so different. All right, first things first, we've got to talk about anatomy and physiology. The entire foundation, literally everything we do in pediatric trauma care, is built on understanding these fundamental differences. How they're built and how their little bodies respond to extreme stress. Okay, so take a look at this. It really breaks down the key vulnerabilities. First off, a child's head. It's proportionally way bigger and heavier. Think of it like a bowling ball on a toothpick. That puts a ton of stress on their neck in any kind of accident. On top of that, their skull bones are thinner, offering less protection for the brain. And their torso, well, they don't have that protective layer of fat and muscle that adults do. So their organs are much more exposed right at the front. What all this means is that one single hit can cause a whole cascade of serious internal injuries. Now, this next part, this is one of the biggest, most dangerous traps in pediatric trauma. It's all about flexibility. See, a kid's ribs are super soft and cartilaginous. The best way to think about it is like a young green tree branch. It'll bend and bend and bend before it ever snaps. So what happens? Their rib cage can get totally compressed in an impact, transferring all that force right into their lungs and heart, and then it just springs back into place. No fractures. You can have a chest x-ray that looks perfectly fine, but inside there could be catastrophic damage. And the same thing is true for their spine. It's so elastic that you can have a devastating spinal cord injury with absolutely zero broken bones showing up on an x-ray. Okay, this is absolutely crucial. How a child's body handles blood loss is completely different from an adult's, and honestly, it's dangerously deceptive. In an adult, you see the blood pressure start to drop pretty early on. That's your big warning sign for shock. But kids, they have this amazing but terrifying ability to compensate. Their bodies will work like crazy to keep their blood pressure totally normal, even after losing up to 25, even 30% of their entire blood volume. The real warning signs aren't on the blood pressure cuff. No, it's a really fast heart rate, that's tachycardia, and slow capillary refill. If you wait for a kid's blood pressure to drop, you've waited way too long. They are on the verge of crashing hard. All right. So let's take everything we've just talked about and bring it into the emergency room, into the resuscitation bay. We're going to see how all these unique anatomical quirks directly shape the critical life-or-death actions that need to happen in those first few moments. Just securing an airway in a child is a whole different ballgame. For starters, their tongue is proportionally huge, and it's the #1 cause of airway obstruction. Then there's the epiglottis. That's the little flap that covers the windpipe. In kids, it's really floppy and kind of U-shaped, which makes it super hard to see the vocal cords. Plus, the whole voice box is positioned higher up and more to the front. But here's the real kicker. The narrowest part of their airway isn't the vocal cords like in an adult. It's actually a ring of cartilage below them called the cricoid ring. And that little fact changes absolutely everything about how you approach intubation. So what about when that child is bleeding out? When they're in hemorrhagic shock? Well, there's a super specific protocol, and it's all based on their weight. You can't just hang a bag of fluids and hope for the best. Nope. You start with a very precise dose of crystalloid fluid. That's 10 to 20 milliliters for every single kilogram the child weighs. You can give that initial dose up to 3 times if you have to. But if they're still not getting better, you stop. You don't just keep pouring in fluid. That's when you switch immediately to blood products. Packed red cells first, then plasma and platelets. And again, everything is precisely dosed based on their weight. Okay, so we've covered the immediate, life-saving stuff, resuscitation. Now let's shift gears and talk about diagnosis. Because of that unique anatomy we keep talking about, kids have these very specific injury patterns that are easy to miss if you don't know what to look for, especially in the head, the spine, and the abdomen. When we're assessing a head injury, one of our main tools is something called the Glasgow Coma Scale, or GCS. But here's the problem. You can't ask a 1-year-old, hey, do you know what year it is? It just doesn't work. So we have an adapted pediatric scale. Instead of being oriented, the best response you can get is an appropriate coo and cry. But, and this is a huge but, the pediatric GCS just isn't as reliable as the adult version. Even more importantly, it's a pretty poor predictor of how a child will ultimately do. A kid could have a really low score but still make a fantastic neurological recovery.
Even the types of brain bleeds we see are different. Take an epidural hematoma. In a kid, it's often caused by a bleed from a vein, not an artery, so it's slower. This can lead to that classic and terrifying lucid interval, where the child seems perfectly fine for a while, and then suddenly deteriorates. Subdural hematomas are another story. They can be more chronic, with really vague symptoms like vomiting or seizures. And tragically, they are often a huge red flag for non-accidental trauma, what we used to call child abuse.
You know, how a kid gets hurt, the mechanism of injury, it often points you directly to the organs that are likely damaged. It's like a roadmap. For instance, a lap belt injury from a seatbelt worn too high in a car crash, that's famous for causing a classic set of 3 injuries: damage to the small bowel, pancreatitis, and a very specific spinal fracture. Or what about a fall onto bicycle handlebars? That's the classic setup for a do-it-on-all hematoma, or even transecting the pancreas, literally cutting it. Knowing these patterns is absolutely essential so you don't miss a devastating internal injury. Okay, we have covered a ton of ground here. We've gone from basic anatomy all the way to resuscitation and specific injury patterns. So let's boil it all down. What are the absolute key principles you need to walk away with? All right, if there's one thing you remember from all of this, let it be these points. First, a child's body just offers less protection. That means you should always assume there are multiple internal injuries. Second, do not trust a normal blood pressure. A fast heart rate is your real warning sign of shock, because they will look fine until they're not. Third, what you see on the outside can mean almost nothing. A kid with no bruises and no broken ribs can be dying on the inside. And all of that leads to the most important rule of all. You treat the mechanism. You treat what happened to them, not just the injuries you can see. And I want to leave you with one last really sobering thought. This comes straight from the source material. The most common cause of unrecognized fatal injury in children is abdominal injury. Think about that. The most common missed killer is an injury to the abdomen. It's just a powerful, powerful reminder that when you're treating kids, you have to have an incredibly high index of suspicion, because what you can't see is almost always the most dangerous thing of all.